Hi everyone. I wanted to discuss with you today about the new treatment for Alzheimer amyloid type dementia and mild cognitive insufficiency, which has been in the news for months. And recently, on July 6, 2023, it got a final approval through the traditional way from FDA, Lecanemab, which is a very fascinating time, understanding about amyloid monoclonal antibody for the treatment of Alzheimer dementia. You've been asked for the last days many questions and wanted to have a better idea about what does it mean with this new treatment, what we're talking about. Is this the cure? Is this the medication can solve the entire problem? Who are the candidates to take these patients? We will quickly review this. I'm sure there's a lot of subjects about this topic, but we try to only focus on this topic as just trying to answer some of the basic questions related to Lecanemab or any future amyloid monoclonal antibody treatment. Today we will discuss about the first, what is the mild cognitive insufficiency? Many of you've seen this on the problem list, on the diagnosis, in the patient chart. What is exactly Alzheimer dementia? What does it mean with the staging of dementia? And what are the traditional treatment that we use for treatment of Alzheimer dementia? And now what has been changed with the recent treatment, and what's the way toward the future? Quickly, I don't want to go on details. This is another topic, needs another half an hour to 1 hour to discuss. But technically, the mild cognitive insufficiency is the earliest stage of memory loss. It's not aging brain. It's not something that is normal. Technically, what we call MCI or mild cognitive insufficiency is not a normal senile dementia. It's definitely some change has happened, which is both subjective and objective. Sometimes the patients or the people by themselves, they feel that they started to have memory loss. Or for example, the best example that I can say, they have a trouble with finding the words. They have a trouble with names. Names is one of the first things that they start. Words is going to be a little bit later. They may going to have mix in their appointment. They forget their appointment. They are a little bit get confused. Like for example, they put the key somewhere and they try to find the key, and they just get exhausted with that. And but the main thing for this memory loss, it's not at the level that impaired with operating most of the daily activity. These people are still able to manage themselves, is still able to drive, is still able to paying the bills, is still able to taking care of their bank account, is still able to do laundry, house chores, is still able to do the basic activity, daily living, like go to take a shower, go to the bathroom, feeding themselves, even the preparing meals by themselves. They are still okay, but they notice they have a problem, again, repeating the same conversation, same questions, and that's kind of like what we call mild. And that definition of mild is very different, because a lot of time, is it the mild dementia or is it the mild cognitive insufficiency? There's very difficult to have a really a line and border, but technically we see the memory loss is starting, and the main things that most of the time other people noticing it, and it's going to come to attention to come to the to bring them to the physician. The physician do some evaluation and then technically say MCI. And then what's the point? The point is that people with MCI have 10 to 15% chance to progress toward the dementia in a year. And it's very interesting. Not everybody with MCI develop dementia. Some of them is a reversible cause, if, for example, we can find it. So a lot of time is a medical problem causing it. Person has hypothyroidism, slow thyroid function. Persons taking inappropriate medication, sleeping aids, the benzodiazepine medications, a lot of it at nighttime, or and that causing the problem, and if you can find it, sometimes just depression, some mental health problem, And that if you can technically reverse the situation, then you're able to handle to MCI is not going to progress toward dementia. Some of them, they just stay at the same level, but 10 to 15% they have a chance to develop toward the Alzheimer. As you probably know, in the very nice picture here, that technically from the mild cognitive impairment, the journey is toward mild dementia, then moderate dementia, and then severe dementia, which is technically the mild, as I said, in mild cognitive impairment, is still the memory loss is not at the level to impair with the day-to-day life tasks. And that's why a lot of time the people just ignore it because they say, oh, I've just got older. And that's actually one of the sentences that I hear a lot. I can tell you as a geriatrician, I don't like this. I don't want it to people say, oh, I'm just because I'm getting older, that's why I have this memory loss. Technically, there are some part of the brain may affected by aging. I will be happy to discuss it in the next sessions about that, but that's the healthy aging brain versus the unhealthy aging brain. But MCI or mild cognitive insufficiency definitely is not healthy. And then it can develop toward mild dementia, moderate and severe, which is impairment with activities of daily living. When it comes to dementia, it's a very interesting. I don't want to go on details what type of dementia we have because that's a very broad. We want to focus on Lecanemab, but dementia is a very big spectrum of the disease as the group of the brain disorder and is not a specific disease. Dementia is a group, technically describes a group of symptoms that affecting not only memory but also thinking, social abilities, and they are severe enough that interfere with the daily function. I can tell you an example. Somebody can have a very bad judgment. Somebody starting to be isolated, withdraw from other people, extreme anxiety, plus the memory loss is always a red flag that dementia is going on, no matter what is the type of dementia is. And then when it comes to dementia, over 100 disease can cause dementia, and technically the basic brain change that happen in 5 of the most common cause of dementia, but still, as I said, there are lots of other disease that can cause dementia, but this is exactly what we talk: Alzheimer, mixed type, vascular, Lewy body, and frontotemporal dementia. These 5 type of them are the most famous one. I would call it celebrity of dementia, and these are the diseases that actually cause a significant brain changes. Other disease can cause the same as well, cognitive impairment, but again, we're talking about this, and this is going to be a global problem. As you know, currently 5.2 million people in the United States, they have Alzheimer's dementia. The number till 2050 will grow significantly. Globally, around 130 million people will be diagnosed with dementia. Just put it also that many people, they have dementia, but they haven't been diagnosed properly. And that dementia will be a leading cause of the death in older adult population. As you know, from the century ago, when Dr. Alzheimer in the hospital in Frankfurt, Germany, found the first case of the dementia Alzheimer, there was a lady who has been diagnosed with the schizophrenia and been admitted in a mental health facility, but he was very suspicious that this should not be schizophrenia. He was curious. The lady had hallucination, but also had severe memory loss, other behavioral changes, anxiety, and he was curious to know that what is the cause after the death of that lady, that he did a biopsy of the brain and found that this is not a schizophrenia, this is a different disease, which he would call a century ago till Alzheimer's dementia. I wanted to tell you that interestingly, till today, from Dr. Alzheimer, we still haven't had any cure for this disease. It's not only is a memory loss problem, but is other issues with cognition, is a communication abilities. That's something that it takes persons from 5 to 12 years dragging with this nasty disease. and really cause a significant stress and anxiety for entire society, for family members, and costs a lot for the healthcare system as well. As you know, as Dr. Alzheimer found in the beginning, he actually found that Alzheimer, which is a leading cause of dementia, is the changes happen inside the neurons. As you see here, there are two protein is starting to deposit inside the brain, amyloid protein and tau protein. And the amyloid plaques, which is you can also see here, and the other one is the tangles, which is the protein we call tau protein tangles, started to involve inside the brain. As you see, healthy nerves are so clean, but the nerves that has deposits of this abnormal protein, it's a sick nerves, it's a sick neurons. It doesn't let the electricity and connection goes through, and depends where this amyloid proteins will be deposited more, then we have the major diagnosis. Like for example, if we have more load of this protein in some area of the neocortex or the hippocampal area, which is a center for short-term memory and learning new things, then we have more significant memory loss problem in that situation. As exactly what we're saying in this picture, you see that the healthy brain, the nerves is extremely clean and there's nothing, but as you see here, we have the tangles of the protein here, and we definitely have the amyloid block, which is technically blocking this nervous system very well. And the main thing that we can actually see that in this picture is it's a development of the tau and amyloid protein. You see in the different colors, as you see here, the red one with the tau and the blue one with amyloid. The first amyloid start to develop, and you see later all the tau in the red color started to involve the brain. But that's, we can actually say how it's going to be affecting the cells and the nervous system, all these tangles that happen inside the nerves. And when it comes to that, in the Lancet in 2013, they had amazing picture in the Lancet Neurology, is actually telling us a lot of important story. Here, as you see in the years that somebody is normal, cognitively okay, then developed MCI and started to have dementia. As you see here in this line, this is the starting time of the memory loss. Okay, this is the first time that you notice that I have a problem remembering names, words sometime, or disorientation. Here is going to be a little bit effect on some of the abilities. This one, when the drivings get affected, but it's very interesting. As you see here, the red is amyloid protein, and this is the tau. This is amyloid protein, this is tau protein. Years before somebody diagnosed with MCI or dementia, the tau and amyloid protein already developed in the brain. That's something that we still do not understand why. We don't know why the amyloid protein and tau protein develop in the brain years before even the memory loss start. Like somebody if diagnosed with dementia at age of 75, probably they have the protein 50 years old when they're 45 years old, 40 years old. That's why the neuroscientists is thinking about a lot of inflammatory metabolic disorder that's causing these problems, and that's why they're focusing at the preventing from that amyloid production. This is the very good question. A lot of scientific researchers are working on it to see, can we stop the production of the amyloid from the beginning? That's going to be a good question for future. Staging of dementia, the two systems that we use, functional assessment staging and clinical dementia rating, which have these two rating. For example, we use a lot of the CDR or clinical dementia rating, but in the clinical situation, I personally use a lot of functional assessment staging, or fast. As you see in the fast staging, we have stages. We have 7 stages of dementia, of the cognition. Stage 1 is normal adult, no functional problem. Stage 2 is a normal older adult that a little bit aware of some functional decline, but we don't see anything. Stage 3 is the time that early Alzheimer's disease start, which we notice some noticeable deficit in demanding job situation. That's probably going to take another 7 years when we have mild Alzheimer, which is early Alzheimer, mild Alzheimer. Mild Alzheimer start to require assistance to some complicated tasks. For example, the first thing is finances, traveling, planning parties. We're going to have the Thanksgiving this year. It's very hard for the mom to do the Thanksgiving this year. As you see, the planning of the party, which has been always so easy, it becomes so difficult. That's the mild, and the average is 2 years. And then they develop toward the moderate Alzheimer, which is require assistance in choosing proper clothes, dress, and anything. That's another 1.5 years. And when we go to stage 6 and 7, stage 6 is moderately severe dementia, which is technically require assistance in dressing. They go to the shower, they go to the bathroom, they have fecal and urine incontinence, which we call a stage 6 or moderate to severe, and that's probably around less than a year. They go to severe stage, which is a stage 7, which is the person is not able to speak. What we call it is less than 12 words, usually 5 or 6 words that is make sense or intelligent words that they can use. And they have progressive loss of ability to walk. They're not able to sit up, they're not able to smile, and they have a hard time to hold the head up. And that's probably the last 1.5 years to 2 years of the life. This is the stage usually that it's the people with dementia can be qualified for hospice care. Not at this stage, not at this stage. They can be, depends on the situation, but technically stage 7 is the time that they can be qualified for hospice care. The clinical dementia rating scale is another way that we do. It's a CDR 0 to 5, which is a 5. Technically, CDR 0 is a very mild dementia. We have a little bit of slight of the memory loss, some difficulty on the time, the problem solving, daily life is slightly impaired. There's not significant. Individual can perform personal care activities with no problem, and that takes 7 years. And then we have CDR1, CDR2, CDR3, which is a shorter time. Like CDR1 is a mild dementia, memory loss, it becomes moderate, especially in the recent events, and moderate difficulty with solving problems, cannot function independently at the community affairs, outside at home, difficulty with daily activity and hobbies, especially complex one, and that's probably 2 years. And then they develop to CDR2, which is a moderate stage of dementia, which is they have definitely more profound. From memories in moderate is a profound memory loss, and that's especially to retain highly learned material. Disorientation, especially to the time, place. They don't know what day of the week it is. They don't care about what month of the month is. They're really not following the calendar. They don't know where they are. Sometimes, I don't know, I'm at home, I'm in the hospital. They really don't understand. Judgment is significantly, it's just getting impaired. Difficulty handling the problems. They have little to no independent function at home. They can only do single chores, and they have fewer interests of doing things, just usually 2 to 4 years. And then they move to severe stage, which is CDR3, which is, again, they're completely going to be disoriented to time and place, no judgment problem at all in solving ability. They cannot participate in a community affair outside at home. They are requiring help with all the tasks of daily living, including shower, bathroom, even feeding sometime, and requiring help with the personal care, and also they become extremely incontinent, which is another 2.5 years. That's a journey, and that they go to stages of the disease. Traditionally, we treat the people with conventional treatment, including cholinesterase inhibitor medication like donepezil or The brand name is Aricept. Rivastigmine is a brand name is Exelon. Memantine, which is a Namenda, and it's helped to delay the progress slightly, help with some behavioral symptoms. Most of the time when it comes to this medication, I will tell the family that it helps to stabilize, to buy the time. It doesn't mean that it's going to be make the people better. It hasn't. It's not significantly makes the memory to get better. It's technically stabilize the some of the situation till you have a little bit more time to prepare yourself for the stages, stage 6, stage 7, stage 5, to know what we need to do. And I personally, as a geriatrician and many other evidence-based, we use this medication with the many behavioral symptoms related to dementia, which can be really helpful. As you see in here, the technically cholinesterase inhibitor or Namenda are the medication initially that we start the people for neurodegeneration because of acetylcholine deficiency. But a lot of other medication is become standard care for people with dementia because they have psychosis, they have anxiety, they have mood problem like depression, apathy, or they have very emotional withdrawn, they have severe anxiety, which we use anti-anxiety, antidepressant medication. Antidepressant medication help with both depression and anxiety, and we also use antipsychotic medication, not because they're psychotic, because it helps with agitation and aggressions as well, is something that we need to understand. But where is this amyloid monoclonal antibody story is coming? As you know, we talk about amyloid. You know, if we have the target treatment for amyloid and able to get rid of amyloid, then you have the answer. And there was 3 medications being available. I mean, Donanemab hasn't gone is still finishing the trial. It's going to FDA approval traditional way from Eli Lilly, but Aducanumab from Biogen has got the accelerated approval, and recently Lecanemab, which is a topic that we discussed, it's got from FDA approval just last week. Aducanumab is the first FDA accelerated pathway for mild dementia. Is actually was very impressive medication because I believe this medication from Biogen actually opened a lot of doors, and that was a very significant. It was very impressive the way that they actually started. I know it didn't go to the clinical practice because the reason that I'm explaining to you, but technically the approval we got from FDA based on 1 study from 2 studies, Emerge and Engage trial, but one of them was showing positive, the other one not. And also the higher dose of medication shows a much better clearance of amyloid in the PET CT scan. And again, in 1 study shows help with the memory loss and function and all this stuff. But I know it was not significant, but it was something that it was impressive. That's why FDA give them accelerated approval. As you probably know, the Aducanumab, when the amyloid plaque reduction happened in the 54 weeks of the treatment, as you see in the picture, it was very impressive. It's actually, we see that all the area of the red, which is amyloid, after a treatment, it becomes all clean. It's like somebody vacuuming inside the brain and gets rid of amyloid protein in the higher dose much better. And at 10 milligram per kg, it was extremely impressive what they have done. And when we look at one of the studies shows that in the higher dose effects on the clinical dementia rating and also MMSE has been difference with the placebo group. But the major controversial started when we have difference between Emerge and Engage trial. 1 study showed effective, the other study shows not. And that was the reason that many of the clinicians in the community, they've been hesitant to start this treatment because they said, how come 1 study shows and the other trial hasn't shown? Was it the trial errors? Was the study hasn't been done? Nobody knows. But the fact is, because of the ARIA, which I'm explaining to you, is a side effect related to amyloid treatment, they actually asked to stop and pause this treatment. And that was the situation with this Biogen production that didn't go to the real clinical practice. Later, on January 2023, as you know, the Lecanemab got started to presenting to FDA, got accelerated approval based on the New England Journal of Medicine study also published in January 5th, which shows the Lecanemab has been effective in some of the rating in both group. And that was very, very impressive when we see the data result. As you probably know, that there was a randomized trial has been done in around the 18 months, which is 1.5 year, and then there was they actually looking for primary endpoint and secondary endpoint. They're looking at the PET CT scan, and they were looking to see in 1,800 people that they've been through this study. As you see here, they are enrolled, some of them placebo, around 800 something. You just go to the control group, and they got the medication, and they look at what happened to the end. That was exactly what it was so impressive, because we're looking at the primary and secondary in the all the panel except the panel B, which is showing the PET result. The panel A, again, we see that some modified intention to treat the population. Then the panel A, we see the result for the primary endpoint. We see the clinical dementia rating. And when you look at the Lecanemab group compared to placebo group, which is a blue one, we see the difference between these two groups. I know some people say, well, that was significant. That was not very significant, maybe marginal, but it was impressive, because we haven't had this data so far for any other treatment that we have for Alzheimer's dementia. Then that's why I just want to say that was something we need to look. I mean, look at the PET scan. The same thing with aducanumab, we saw that was significantly helped with the group of lecanemab that definitely dropped the amount of the amyloid protein. I mean, look at the other secondary endpoint like ADAS score with the functional. We actually see that the group of lecanemab, they did better compared to the placebo group. That was the very impressive data. And the other side, when we talk about ARIA, which is, again, as I said, is amyloid-related imaging abnormality, which is we have this is a side effect of the using monoclonal antibody. When you absorb the protein from the brain, the area either that can be swelling, can be microbleed. Now, that's very important to understand. Like, for example, we have either what we call ARIA-H, which is a hemorrhage, microbleeding, or we have a ARIA-E, which is a swelling in that area. That two things is actually the side effect of that. Now, ARIA in the first medication, aducanumab, it was significant, 40% more in higher dose of 10 milligram per kg. And the people, they have ApoE4, which is a gene in the homozygous, which is F2, it just more have the risk of the ARIA side effect. And but majority of them, they've been very asymptomatic. Even they have the positive MRI. If they are symptomatic, they may have nausea, headache, some dizziness, maybe some visual change. These are the symptoms that we need to watch, and that's something that we saw in that. And interestingly, in the group of lecanemab, the ARIA has been significantly lower, 21%. And just like ARIA-E, 2.8% compared to 26% of aducanumab. But that's very, very impressive with the lecanemab. It was there, but it was much better. And who are the people, based on what I talk about, ARIA, hemorrhagic or bleeding, maybe not going to be candidate for that? Definitely the people take blood thinner medication. People taking warfarin, like Eliquis, Paradoxa, Xarelto. These are the medications that if you take it, you have a high risk of bleeding. You cannot take this this treatment. The people recently have bleeding stroke. People are old geriatric. People are aged more than 90 years old. They cannot take this treatment. And the people with the cerebral amyloid angiopathy, which is a situation that they have a microbleeding in the brain, these people are not a good candidate for getting this treatment. Eisai company had a comments about the people have homozygous ApoE4. We can do genetic test prior to do that to see if you have this gen. Technically, ApoE4 is a gene, or that if you have it, then you have a higher risk overall if you have a family history for developing the Alzheimer dementia. Higher risk, but doesn't mean that everybody has ApoE4 will develop dementia. No, that's not the case. If you have the genes, you have a higher risk. Okay, but before the test, we can actually do the genetic test, and we can see if you have an ApoE4 in the homozygous, that means two genes. We need to discuss, to talk about risk and benefit of Lecanemab, the treatment. We need to do it. You don't need to have the testing 100%, but many of them, like Eisai company, highly recommend that we should have the ApoE4, because then we have a better control there. Infusion time is around 1 hour of infusion. The dose is 10 milligram per kilogram of your weight, depends on your weight. The only part is the difficult is 18 months, which is 1.5 years of your life. Twice a month you have to have infusion. If you miss a dose, you need to have the second dose administered as soon as possible. One of the other part, the problem is the multiple MRI for monitoring the ARIA. Definitely at the dose of 5, 7, and 14, we should have the MRI plus the one MRI at the baseline. Depends on your ARIA situation, you may have additional MRI. That's why prepare to go back and forth to this MRI machine multiple times during this 18 months. Definitely some side effect is related to the reaction to infusion time, which is again like chills, rash, maybe itchiness and headache at the time. These are all self-treated. There's no really anaphylactic reaction. And you remember during the COVID, a lot of people had the reaction to vaccine, but that's not the case. But they're kind of similar. Anytime when you enter a foreign material to your body may have some reaction. That's why just prepare yourself for this kind of reaction. Most of the time, infusion center, they have the rescue medication they can give you there, and then it's just going to be completely gone. But headache in 14% of people. Some people develop diarrhea, very small number. But overall, always the monoclonal antibody infusion, even during the COVID time, I remember diarrhea is one of the major side effects. And then less than 4%. It's not significant, may have some palpitation, may heart arrhythmia, atrial fibrillation. This is something that we like to have an expert doctor always following up with your primary care. Be really on the top of the case for 18 months. Make sure to monitor you closely. I like the one of the things is wrap up. When it comes to wrap up, is an effective treatment, Lecanemab, in the mild amyloid Alzheimer and mild cognitive insufficiency. And first step is evaluation. Many of your loved one have the diagnosis of MCI or mild Alzheimer, but they really don't have a correct diagnosis. The evaluation of if you are, you need to have the amyloid positive, either through the spinal fluid or PET amyloid scan, which is not covered by Medicare, PET amyloid scan. But then you have to have evaluation, genetic testing, memory, functional assessment. Even that's requirement for Medicare purpose for registry of the Medicare is so important, and the review of all your potential risk. Medicare is going to pay 80% if they approve, but again, Medicare is not going to approve if none of this workup have been done. You need to have a consultation. You need to have the functional assessment, the amyloid, the memory test, baseline MRI, everything put together, and they will review it, and if they approve it, they will pay it. There's a registry they need to do. I've tried to answer some of your questions here. The first question is everybody candidate for the first for this treatment with MCI? The answer is really no. You need to be evaluated. You need to have a good evaluation, do the functional assessment, memory test. If you are, depends on where you're standing. The doctor send you to do more further testing, and that's very important. The other question a lot of people ask me, I'm taking blood thinner medication for my atrial fibrillation. Is it worth that I stop it for 18 months and then do the treatment? I do not recommend that. I think it's just the most important thing I all recommend. If If you are so crazy about this treatment, I will say you need to discuss with your cardiologist and really put the risk and benefit that do you really need to be on stop this medication. But I personally, as a geriatrician, I don't think you should give it a try, because the atrial fibrillation, think about it, risk of a stroke is actually going to be very high, and you don't want that. So people ask me that I take aspirin, can I get the treatment? The answer is yes. You can get the treatment. There's a question about if you get two kind of antiplatelet therapy, like for example, people take aspirin and Plavix. That's something we need to really discuss. It's not contraindicated, but definitely if I treat you for Lecanemab, if any other physician treat, we pay more attention to this treatment. What happened when infusion is stopped? 18 months, I'm done. And now what happened? Well, first, I'm very sure if you're successfully able to do that, then you have the more clean brain on the PET MRI, on the PET CT scan. But the other things that we still don't know, honestly. We need to know more long-term outcome of this all monoclonal antibody treatment, and then we do that. How do I know if I'm amyloid positive? I explained to you, you either have to do a spinal tap removal or you have a PET amyloid scan. And does Medicare pay for PET amyloid scan? Unfortunately not. It's a very accurate scan, but they don't pay for it. I do not have memory loss, but I was curious. I just did the amyloid scan and I become positive. Can I get Lecanemab? The answer is no. First of all, you should have, memory loss. But if you're a healthy person with the amyloid positive, there are some studies running around the country for healthy individual amyloid positive to see, or even the healthy individual, that they want to see if the treatment, they never developed amyloid. I have to say that Stanford University in the memory clinic, they're running kind of this study. Contact them, and if you're interested, if they're still taking patients for that purpose, it's actually a good idea to discuss. But they're all over the place in the country. But I have to tell you, Stanford is also doing it right now. What is my first step to get the treatment? As I said, consultation evaluation is so important. Prepare yourself mentally for 18 months journey, and think about that you should have a multiple MRI during the time. Should I wait for Eli Lilly product, Donanemab? How about this? They are going under traditional of FDA approval. They have the press release data, which was impressive. Trailblazer Alzheimer 2 trial shows nearly half of the patient taking this treatment, which is the same monoclonal antibody, had no clinical progression at 1 year, defined as no decline in the clinical dementia rating, a CDR-SB, which we have, compared with the 29 patients on placebo. And it shows the 35% significant help with a less decline compared to placebo, and has the ARIA side effect a little bit higher than Lecanemab, but I just want to tell you that it was very impressive. What are the beginning of the new history? It's just true. We are really on the new history. It's the first time that we see the effective treatment finally in this situation. We will learn more in the near future that if this amyloid monoclonal antibody has the positive effects in the long-term outcome. There are more studies coming. Some of scientists working on metabolic treatment for like insulin insensitivity, some of them on anti-inflammatory, the tau antibody, because again, some people only have tau protein and issues, and then that's this category of people, they not respond to this amyloid monoclonal antibody. Now they're working on a lot of tau protein antibody. I believe that 2023, it's really a good year. Finally, after a long time, that we see some lights in the end of this tunnel, and I'm very excited about that. One of the things about a lot of people say, what about slow the progress? I want the cure. But why? Is it better? Yes, it is better. It's helped with the quality of life, of course. It helps with also help with the society. If you have more time that you just stay in the mild stage and do not progress, as I explained to you, after like 2 years, 7 years, and 4 years, You actually can spend more time with your family. You really stay able to travel. You're still able to do a lot of function as a day-to-day basis, and that's definitely a positive point. And and again, the other thing is the cost. We are going to have a significant increased risk of the cost of the healthcare just related to dementia care. And think about if you're able to delay it, that's really going to help the good nationally and globally all around the world with aging population, especially with dementia. 130 million people in 2050. Imagine if they're all going to be in advanced dementia. It will be chaos. No, I highly recommend to go to Alzheimer's Association. It's actually a great group of people that they are providing a lot of information for education, for learning, for patients' education as well. They have a hotline. They have that you can call. They have people that they can help you with that. They always have events. I personally say as a physician, I really enjoy the information. I always encourage my patient to check on Alzheimer's Association and see what they have. Any question you have, you can call us at our office, my office for that, for evaluation. Are you qualified for a Lecanemab treatment? We'll be happy to see you and at least see that you are the right candidate or not. You can email us at info@geriatricsconcierge.com and we can actually help you with this situation. Hopefully, we see more and more in the next years with this treatment, and hopefully this is the new beginning of the new history right now. Hope everybody stay healthy and happy. Thank you.